Welcome to Mastering Public Health. This episode covers Chapter 3, Program Planning Models. Our focus is how planners move from needs to action using structured models that guide assessment, intervention design, implementation, and evaluation. These models create a logical sequence, help align policies and education, and support measurement of impact and outcomes. Learning objectives. By the end of this session, you should be able to explain why models are essential for effective planning, describe major planning models and their phases, distinguish when to use each model, and connect behavior change theories from Chapter 2 to specific steps in program planning. Section 1. Why models matter, from individuals to ecology. The first point is that models are blueprints. They sequence assessment, design, implementation, and evaluation, so programs are coherent and measurable. The second point is the ecological shift. Modern planning looks beyond the individual to environments, sectors, norms, and policy, so that the healthy choice becomes the easy choice. The third point is that effective plans start with understanding the health issue and population, selecting appropriate educational and policy strategies, and establishing objectives, milestones, and evaluation plans from the outset. The social ecological model foundation. The social ecological model frames health within interrelationships among individual attributes, settings, sectors of influence, and broader culture. It ensures planners look beyond knowledge and attitudes to the structures that enable or impede healthy behavior. Section 2. Proceed 9 phases. The first model is Proceed, the most widely used, offering a comprehensive ecological approach in 9 phases. Think of Proceed as the diagnosis and Proceed as the treatment and testing. Proceed, assessment and diagnosis. Phase 1, social assessment. Understand quality life and community priorities, issues like unemployment, safety, and social cohesion. Phase 2, epidemiological assessment. Identify the health problem, affected populations, and measurable goals using epidemiologic and surveillance data. Phase 3, behavioral and environmental assessment. Specify the behaviors and environmental conditions that most strongly drive the health outcome. Phase 4, educational and ecological assessment. Diagnose changeable determinants. Predisposing factors such as knowledge, attitudes, and beliefs. Enabling factors such as resources, access, and skills. Reinforcing factors such as social support and incentives. Proceed. Implementation and evaluation phase 5, administrative and policy assessment. Align organizational capacity, staffing, budget, and policies. Identify constraints and opportunities. Phase 6, implementation. Deliver the intervention, education, social marketing, environmental change, or policy action according to plan. Phase 7, process evaluation. Verify fidelity, reach, dose delivered, and adoption. Phase 8, impact evaluation. Measure immediate changes in predisposing, enabling, and reinforcing factors and in behaviors and environments. Phase 9, outcome evaluation. Assess long-term changes in health outcomes and quality of life. Practical note. Proceed is strongest when problems are complex, multi-level, and require both behavior and policy solutions. It is assessment-rich and ideal for comprehensive community initiatives. Section 3, Match, multi-level approach community health. Match is also ecological but implementation forward. It spends less time on early assessments than Proceed, and moves quickly toward evidence-based interventions and policy levers. Its phases are goal selection, intervention planning, program development, implementation preparations, and evaluation. Use Match when direction is known, time is constrained, and you need to move efficiently into multi-level implementation. Section 4, Consumer-based health communication models. When the aim is population-wide awareness or motivation, marketing-informed models help segment audiences and tailor messages. CDCynergy, CDC. This model applies audience segmentation, message strategy, and channel selection. Phases include understanding the problem analysis, communication planning, program and evaluation development, implementation and management, and evaluation. Making health communication programs work, NCI Pink Book. A 4-step circular process emphasizing continuous planning, implementation, assessment, and improvement with a strong consumer focus. Use these when behavior change hinges on communication reach, salience, and repetition at scale. Section 5, Community Level Strategic Models. Community health often requires formal participatory planning with local partners. MAPP, Mobilizing for Action through Planning and Partnerships, a community-driven process developed by NACO. Phases include organizing for success and partnership development, visioning for assessments, identifying strategic issues, formulating goals and strategies, and the action cycle that iterates planning, implementation, and evaluation. Map it, Healthy People 2020-2030, a simplified, nationally aligned framework. Mobilize, assess, plan, implement, and track. These models shine when multi-stakeholder ownership and strategic prioritization are essential. Section 6, Integrating Models with Behavior Theories. Program models are the scaffold. Behavior theories from Chapter 2 provide the content. MAP constructs to phases. Use HBM to surface perceived threat and barriers during assessments. Apply TTM to segment by readiness and tailor strategies. Use SCT to build self-efficacy with modeling and practice. Leverage TPB to address norms and perceived control. This alignment ensures that each step in the model targets specific, measurable determinants of change. Section 7, Choosing a Model, a Decision Heuristic. If the issue is complex and multi-level with uncertain drivers, choose PRECEDE, proceed for deep diagnosis and full evaluation. If you already know priority goals and need to implement across levels fast, choose MATCH. If mass communication is central, choose CDCynergy or the Pink Book. If success depends on partnerships, local governance, and priority setting, choose MAP or MAP it. Section 8, Common Pitfalls. There are 3 frequent errors. First, skipping assessment and forcing a predetermined curriculum. Second, confusing strategy with model, mixing tactics without a coherent sequence. Third, evaluating outcomes but not mediators, making it impossible to learn whether the pathway worked. Avoid these by documenting your model choice, your logic model, and the construct level measures that map to each phase. Section 9, Mini Case Illustrative. Consider rising hypertension in a mid-sized city. PRECEDE identifies poor access to healthy food, low walkability, high sodium intake, and limited self-efficacy for label reading. PROCEED aligns partners, budgets, and policies, implements a combined approach. Corner store labeling, sodium reformulation with restaurants, walking trail signage, and skill building workshops. Process evaluation tracks reach and fidelity. Impact evaluation measures changes in self-efficacy and purchasing. Outcome evaluation assesses blood pressure, trends, and quality of life. This illustrates how theory-informed constructs ride on a model scaffold. Conclusion. The key idea is that models provide structure for complete sequence planning. A second idea is that the ecological lens ensures strategies address environments and policy, not only individuals. A third idea is that theories from Chapter 2 populate each phase with measurable determinants so programs can be effective and sustainable. Educational summary based on Introduction to Health Promotion, 2nd edition, Chapter 3. All rights to the original text belong to the author and publisher. Produced by Mastering Public Health.